Moving, it is moving also?
You have not moved. Move once. Let's see. Go to next slide.
Moving?
No, not yet. It's not moving.
Not moving.
No,
So it has to be made full screen.
Make full screen and also click on this slide, Rishi. Click on the slide, not on the. If not moving with the computer.
No, it is moving in my screen, not moving with you. So I'm just resharing once again.
Please reshare.
I'll do that.
Try moving now.
Visible, sir.
Just a minute. It is moving?
No, yeah, moving now.
Perfect.
Moving?
Perfect.
Moving?
Yes.
Perfect.
Yes, sir.
Yeah. Thank you, Dr. Archana, for good words. Thank you, Dr. Ashok Das, sir, and a big thanks to Dr. Alok Kanungo for this opportunity. And it was a dual benefit for me. I learned whatever I'm telling you people, and I have learned from these two wonderful speakers, and I'll be further learning from the panel discussion. So my topic is a very basic topic, which is, I think, required in a day-to-day practice. So clinical issues in management of type 1 diabetes. And what am I going to talk is basic insulins, monitoring technologies, and social issues. Technology, I was looking, there is a full session, so I'll briefly touch and move. The hard facts of type 1 DM is, it was 2017 data that life expectancy is less than 12 years than of general population, and the risk of cardiovascular event is 10 times than of general population. So a very humble request to those who are treating type 1 diabetes, adult type 1 should be protected by statins. India is the second largest country to have type 1 diabetes, first being US. And a word of basic advancements. We have analog and rapid acting insulin. So I'll request everyone to use, if possible and affordable. We have designers insulin also available, from Glargine to U300 to Dicmer to Degludec. So you have full choice. Ultra-fine insulins are available. Much better quality pens, disposable pens. Some of my type 1 patients have started using disposable, and then they stopped using regular pens. Much better glucometers, advanced glucose monitoring system. We have been discussing artificial pancreas. So there is another, there was a talk on pump and everything, a session prior to us. I think what is the important thing about type 1 is, and that what we have learned in last 30 years. It was 1993, 94 when I started endocrinology. People used to ask what is new, and that point of time the understanding was, once complications come, they are progressive. And Professor Das and all my senior Dr. Alok would agree, even Archana would agree, that that point the understanding was, once it comes, they will progress, not in type 1, but in type 2 also. So that was the first study that showed that good control not only arrests the complication, but also reverses. So now we have more than 30 years of follow-up diabetes control and complication trial. The follow-up of diabetes study is known as EDIC summary, epidemiology of diabetes intervention and complication. It showed categorically that microvascular complications are reversible, long-term benefits in macrovascular events. Initial control is the success, and it is a key. So whenever a diabetes comes younger, first time detected, go for best control, no change in cognitive function. What was observed that in intensive arm of DCCT, that because of very nice control, 7.6 we were discussing, the more chances of hypoglycemia. Was there any cognitive dysfunction? No, there was no.
The slides are not moving.
All right. Is it not seen moving? Okay. I'll just reshare. It is moving? Full screen is visible? Slides are moving?
Yes, now it's moving. Yes.
It is moving. All right. Sorry. So this is plan of the talk. I've discussed about hard fact
Yes, till
advancement.
here it was visible. Next, right.
So DCCT, I think this is a trial that showed us the way. Not only type 1, because UK PDS trial came, I think, 5 years later. So this was the trial that showed a way to type 2 diabetes as well. And what was observed that in intensive arm, we had a suspicion that in long-term follow-up, because of more frequent hypoglycemia, the cognitive function should be disturbed in active arm. But long-term follow-up, there is no cognitive change in adults with type 1 diabetes. So the barrier was tough to keep low A1C with lesser frequency of hypoglycemia, which I shared. And the golden rule is take advantage of metabolic memory. Whenever best control in beginning plays the best role and gives you a long-term best results. Yes. Now I'll be talking a very basic thing, understanding to use insulins. What insulin should we use? Anyone? Because a lot is happening. Many of type 1 patients are mixtures, and some of them are doing well. And I'll say very minority of my patients are there on mixtures. And in spite of telling them they are not shifting, but if you look CGM and do frequent monitoring, there are gaps. So it is better say no to mixtures. 1. MDI multi-dose insulin is a preferred choice. 1 long-acting and 3 short-acting, or 4 short-acting in children. Then MDI plus CGM or flash CGM is always encourage using monitoring, because if these two things are used together, the results are best. Talk about pump. First patient should be on MDI plus sensor. Then if patients agree, pump, and pump with sensor. So this is the order which we are using. The different types of pumps which we have been discussed. Now we have latest 680G pump. Again, it has been discussed. And the problem is pump should be talked about with type 1. And I was listening to the discussion. This is the latest Medtronic pump 680G, and it is recommended with patients with type 1 diabetes, not with type 2. Some of my type 2 patients are also on this pump, but it is recommended with type 1. There is a hybrid loop system in the pump. The basal system is automated. Bolus is to be given based on meals and carb counting. Ultra rapid insulin yields better results. So technologies, those who are listening to this, the SPAT guidelines are insulin pump, especially sensor augmented pump is a useful therapy. And barriers in pump therapy are unnatural attachment, stress.
I think, Rishi, it has not moved beyond the things you said just now. For the SPAT guideline is not coming. It is with the EDIC summary slide.
Rishi sir, could you try right click and doing next?
Click or just click over the slide on your system.
Okay. Is it moving? I'm clicking.
Not yet.
Oh, no.
Right click and then press the next on top of that.
Right click and then?
His next comes on top of that.
Actually, it is moving in my screen. Just a minute. It is moving now?
Your slide seems to be very choosy for you only, Rishi.
Right. Jargar sir, not able to work. I'm just quickly stop share and I'll just. Hello, I'm following you. Is it coming full screen? The screen is there?
Yes, is there. No.
Is it moving? Just a minute, I'm moving. It is moving now?
Yes. Just like that, on top of that, press that next.
It is moving?
Yes, it's moving.
Okay, sir. Thank you. Thank you for the help. So where was I? This is mixture. Everybody seeing understanding to use insulin? This top heading, is that all right? What is the
Understanding to use insulins.
right, correct. So I'll move faster. So I have discussed this. I think only message is avoid using mixtures. 3-dose, 4-dose insulin, 1 long acting and 3 short acting is the answer. Pump therapy is a very useful therapy. I think it should be encouraged, and the sole reason is it makes patients almost like non-diabetic, but there are barriers. And I was reading the SPAT guidelines. The barriers in insulin pump therapy are unnatural attachment, lipohypertrophy, decay, financial. I think more than financial constraint is the mental barrier. Many of my well-off patients, they are not using. I mean, money is not the issue, understanding is not the issue, but the mental barrier of something putting in body is the biggest issue. And now we talk in terms of glycemic variability in time in range. CGM and flash glucose monitoring are truly useful and safe. Metformin in type 1 diabetes. This slide is visible, sir?
Yeah, bilkul.
All right. So a word about metformin in type 1 diabetes. It is helpful in weight reduction, insulin dose reduction, but as the number of trials, we have not found much change in HbA1c. Type 1 diabetes in dapagliflozin, there have been a trial, and compared to placebo, significant reduction in HbA1c was seen, weight loss, change in insulin doses, 8.8%, no change in hypoglycemia, no difference in diabetic ketoacidosis. But latest recommendations are that this is not recommended. So my understanding is the adult diabetics who are controlled, who understand they're a bit overweight, why not they should be provided cardiovascular and renal protection, because this salt, the SGLT2 inhibitor are protective even to non-diabetic. So that is my point. Then considering educating individuals with type 1 on matching prandial insulin doses to carb. So what is most important is a carb counting. I'll talk. And the psychological counseling is a very, very important. I think we have had 2-3 sessions with a clinical psychologist with some of our patients. I thought the moral boost up, the understanding, many of the questions we are not able to answer, they answered. That is very, very important. Those who are dealing with type 1, even with type 2, it is required, but type 1, it is very, very much required. The psychological counseling, and if individual counseling somehow because of ROSAS is not possible, go for group counseling. Maybe one counseling very recently we had, I think, around 40 children above 18 years, and a clinical psychologist spoke for them, and it was out of the world talk. The carb counting, protein, fat counting, this is by and large in clinical practice is not encouraged. So make our children understand that carb counting is very important. And lastly, a systemic review recommends that 30% increment in bolus insulin doses for the meals containing high fat and protein, because proteins and carb and fat we seldom include. So now this is also included. But basic thing is every children with type 1 diabetes or even type 2 who are dominantly on insulin, they should know the carb counting. Monitoring is very important. Self-monitoring of blood sugar to be measured 6 to 8 times a day for aggressive management. Real-time CGM data is very, very important, but they should be made acquainted. They should understand and they should use it. Intermittent self-monitoring, again, those who are not using these technological things, they can use basic monitoring. Diabetes center personnel should advocate to. This is again very important, that if we can provide regular strips, and sometimes even we are providing, patients are not doing. So CGM, this is all about CGM. This is Guardian Connect. Once I put to myself, I think it gives a very nice thing. I mean, look at the data, and this is a very full. The AGP metabolic glucose profile is approved up to the age of above 4 years. Hypoglycemia should also be discussed. Very important. And most important thing is hypoglycemia awareness for long-standing type 1 diabetes patients. And another important thing is whenever hypoglycemia occurs, whenever it occurs, people go for sweets or chocolates or something sweet. But what is most important thing is at that point of time, give pure uh, carbohydrate in form of glucose or sucrose. So the answer is either glucose or fruit juice or cold drink, because these are the things that contain pure carbohydrate. Because if you are giving sweets, the chocolates or the gulab jamun, they contain fat and complex carbohydrate too. This is, I think, very important. Diabetes to be managed with brain. This is a science. And type 1 diabetes to be managed with brain and heart. Archana is sitting, Professor Das is sitting, Alok is sitting, they can understand. And clinicians truly dealing with type 1 diabetes need to handle them with love and compassion. I think I wrote long back on this India Today, unknown face of type 1 diabetes. So discuss these issues. A very brief about social issues. I'll be finishing in this 2-3 minutes. There is a school and education, food choices, whether to reveal diabetes or not. That is another big issue. I mean, I was discussing with Dr. Leja Das if we can discuss 1 or 2 questions on social issues. Social gathering, whether they should tell diabetes or not. What is happening in employment and job? What is the legal status? And relationships and marriages. School and diabetes. Teachers and support staff behavior is variable. Many schools are not aware of hypoglycemia and snacks before games. Meal in class is not allowed sometimes. So that is the status. I think very recently we published a paper in Pediatric Endocrinology, Journal of Pediatric Endocrinology. It was the multi-center study and I was part of it. Type 1 diabetes, self-care in urban schools, and what it tells: refuse permission to check blood sugar, prohibited child from sports, excursion, did not allow pre-sport snacks. Private schools had a better infrastructure, but equal frequency of non-supportive behavior. So healthcare professional may need to focus on lesser educated parents and children in government schools to improve diabetes care. College and diabetes, whether reveal or not, healthy, unhealthy, moving with flow of life, same time managing diabetes is a challenging. But if at the back diabetes is in the mind, they can do. Marriage and diabetes is, I think, is still a big issue. People with type 1 diabetes are as normal as anybody. We talk, we say, but in reality it is not. And they have full right and can handle the responsibility of marriage. What is happening? People hide their diabetes. Males more, females also, but creating problem. They undergo number of refusals, even if they declare that they have diabetes. If asked for opinion, many times, I mean, this is again request family doctors that if type 1 diabetes is controlled, A1C is normal, no complication, he or she is as normal. So they should not say no to the marriage. So that is another part. I think Professor Jargas is there. He witnessed one of our meeting 13-14 years back, and the solution to this is encourage them to be independent, smarter, and carry themselves nicely. Team management involving patients, parents, social workers, and doctors. Team and society equilibrium. That is, again, the society should know what these type 1 diabetics are there. Convince family doctors and society that they are normal as anybody else. And finally, I'm giving you today's thought. Why most of affordable type 1 are not on pumps. So this is my thought I just wanted to share with you. And to conclude, DCCT addict trial showed the path that good control from beginning is very useful in terms of long-term outcome. It's more than 30 years of follow-up. Monitoring evolved as key component of complication-free life, because until unless we know, we can't do it. Awareness of individual, family, and society continues to be important. Lots of social issues need to address, especially relationships and marriage. And this is one of our big, I think for the first time in country, we did a fashion show with type 1 diabetes. So I lived with type 1 diabetes for last, I think, 28, 29 years. Thank you so much for your kind attention and apologies for interruption.